Welcome to Health IQ. I'm Dr. Alan Siegel. Today we have a very special guest, Dr. Sadaf Lodhi. She's a OBGYN, thank you, here in Chappaqua, New York. She's in private practice, concierge practice of sorts. She also has 20 years experience as an OBGYN, focusing on women's health, women's sexuality, and a few other topics we're going to talk about today. So welcome, Dr. Lodhi.
Yes, thank you so much, Dr. Siegel, for having me on. I really appreciate it, and it's my pleasure. I'm so happy to be here.
Tell me a little bit about your practice in general. You know, in today's day and age, not too many private practitioners anymore doing what you're doing. What drove you to be a concierge OBGYN, female women's health specialist?
Yeah, so I really, well, first and foremost, I really enjoy women's health. That's always what I wanted to do ever since I was younger, and I really felt like a lot of times women weren't at the table when we were discussing women's health, and I think it was only in 1993 when women actually became part of research, and we were actually doing research on women's health. So it's not that long ago, right, that women actually became part of the conversation. And so that I really enjoyed that. I really wanted to focus on women's health. And then, the whole concierge idea came to me because I was tired of working in like a factory, right? So you're in a typical, group practice, and you get like about 5 to 6 minutes to really see a patient. At most they block off 15 minutes. For maybe like an annual exam, you'll get like 20 minutes. And so you really don't get a chance to have a real in-depth conversation with a patient about what it is that's bothering them, and what's going on. And in a typical practice, you only get just very few minutes, and all they can tell you is I'm feeling fine or I'm not feeling fine, and then forget it. If a patient tells you she's having decreased libido, that conversation in itself is like an hour long. So it's really, you just can't. The current model of healthcare, it just does not allow for those deep, in-depth conversations where you can really find out what's going on in a patient.
Yeah, and I guess as an OBGYN, like you said, there's a lot of details that go into a health exam, a personal exam. Women, as they're going through their life, have changes, whether it's, trying to have babies, postpartum, whatever, and then going on through life, and things change, our bodies change, and we have a need for different things, and going on that journey with them versus like rushing, seeing someone for 5 minutes, maybe never seeing them again because maybe they didn't have a good experience because they couldn't have a good experience. So having that personal touch. So I think it's really great that you're doing this. I honestly, I wish we can go back to private practice back in like the 50s and 60s when we're doctors. So moving on to like, what you're seeing day to day and what your real specialties are. What are the more common things that like women will come to you for in terms of like, treatment or assessment, or things that are like kind of day to day, or that would reach out to our audience?
Yeah, absolutely. So, so in my practice right now, what I'm focusing on is gynecology. So out of my private practice in Chappaqua, I'm not doing delivery, so I'm doing gynecology, and I focus on the whole women's life health, right? That's what Femme Vie Health means. It means women's life health. And I focus on anywhere from puberty to menopause, post-menopause. I do all of that in between. My specialty right now is I focus on perimenopause, menopause, and sexual health. I feel that those are areas that a lot of physicians are not taught. I am a Menopause Society certified practitioner, as well as an ISSWSH fellow. ISSWSH stands for the International Society for the Study of Women's Sexual Health. So I focus on sexual health, and I think that that is such a taboo topic that nobody talks about. A lot of women suffer with female sexual dysfunction, whether it's with pain, pelvic floor dysfunction, like we talked about, problems with arousal or libido, and these conversations just cannot be had in like 5 to 10 minutes. You really need a long conversation to discuss, what is at the root of this issue that's going on with the patient.
Well, let me interrupt you for a second. So let's tie some of these things together. So you have menopause, perimenopause, all the different stages of menopause.
Absolutely.
And then you have libido. How are they related, and how do you address those, from a hormone replacement? Let's tie that together for our audience here.
So perimenopause is the time right before menopause. So just for anyone that may be watching, maybe doesn't really understand the difference between perimenopause, menopause, postmenopause, what are all those terms, right? So perimenopause is the time period right before menopause. Menopause is when a woman goes a whole year without a period. And so perimenopause is a time frame right before that. What's really important to understand is that different ethnicities go through perimenopause for different lengths of time. There was a study done in 1994. It was called the SWAN study, and it was a multi-center study. It looked at basically women in midlife. It was a multi-center study, and it looked at what it was that women went through. And what they noted was that African American women and Hispanic women tended to go through perimenopause for a much longer time. So we'll say that Caucasian women go through perimenopause for 7 years. African American women and Hispanic women tend to go through it for 10 years for African American women, and Hispanic women about 8.9 years. They think that perhaps the difference, why different ethnicities go through perimenopause for different lengths of time has to do with kind of like their life experiences. And we also know that systemic racism can affect women, can affect their DNA.
I was going to ask maybe like, ethnic backgrounds, socioeconomic backgrounds,
exactly.
work backgrounds,
Yep.
All of that.
All of that, the stress,
together.
Absolutely, 100%. So there's something called weathering where the DNA actually shortens, their telomeres actually shorten, and makes certain ethnicities more at risk for certain conditions like high blood pressure, perhaps diabetes, things like that. We know that South Asians have a higher risk of diabetes, but also heart disease. So we have to kind of go back and figure out what happened there and why is it that they are more at risk for those certain conditions. Same thing with perimenopause. So we know that African American women and Hispanic women tend to go through perimenopause for longer periods of time. Caucasian women for about 7 years, and East Asian women about 5 years. So that's really important for providers to understand, because when a woman comes to you and says she's having hot flashes and night sweats, sometimes practitioners will be like, no, you're too young to go through that, when actually they're not. So if we're saying that the mean age for somebody to go through menopause is 52, if you subtract 7 years from that, say for a Caucasian woman, she can start perimenopause around the age of 45. And if not sooner. A lot of times I'll ask women to tell me, around what age their mom went through menopause, so I can figure out, perhaps they're going through menopause, perhaps perimenopause, perhaps they're not.
And what health issues might they be experiencing while going through, various phases, like whether it's when does the libido really start to go down, or other things like, osteoporosis potentially, or other things that are tied into, perimenopause, menopause, other symptoms. Obviously the hot flashes being a symptom, but what other health effects can go along with that, along that journey of
there's so many. Patient. So when we talk about perimenopause, one of the first symptoms. So I think that so there was an article written in the New York Times, right? That it was the headline was "Women have been lied to about menopause," and the author of that New York Times article actually said her first symptom was brain fog. I know a lot of women feel that way. They'll go into a room, they'll forget what they were doing, or perhaps, they won't even take, a promotion in their jobs because they're afraid that they won't be able to perform at their highest level. Oprah talks to us and she says that her first symptom was arrhythmias, cardiac arrhythmias. So there's so many symptoms that happen. Some women can have joint pain, dry eyes. We talked about brain fog, hot flashes, night sweats. Women are definitely at risk for osteoporosis as well. We know that once women get into post-menopause, right? So menopause is a time when women do not have a period for a whole year, and after that time frame, then they're in post-menopause, and women are definitely at risk for osteoporosis. We know that one of the ways to prevent osteoporosis is an FDA-approved medication that we know we have, which is estrogen, and estrogen is really good at preventing osteoporosis. Estrogen helps with so many things. It helps with, we don't prescribe it for cardiovascular health, but we know it helps to dilate the blood vessels, so it can help with cardiovascular health, and it's like a side effect, like in terms of like helping with heart health. But we definitely do not prescribe estrogen for heart health. But we do prescribe estrogen for vasomotor symptoms like hot flashes and night sweats. It's FDA approved for that. Also, there's something called genitourinary syndrome of menopause, which is such an important topic that people just do not talk about. And basically what that is that the changes that occur in the vulva and the vagina of women during this time of perimenopause and menopause. And what happens is that as our estrogen declines and ultimately after postmenopause essentially goes down to zero, women can see effects in their vulvar and vaginal area. What happens is that that tissue starts to get thinner. Women can have pain with intercourse. Women will notice decreased lubrication. Their libido goes down because the testosterone also goes down. But also what happens is that they start to have pain with intercourse. Anything that gives you pain, you're not going to want. So that's going to cause decrease.
Let me stop here.
Yeah.
We talked about a bunch of different hormones right there.
Yeah,
so let's go to the hormone effect and the
Sure.
hormone treatment here.
Yeah.
Estrogen. All right. What form of estrogen? How is it prescribed? I've heard of like progesterone creams, estrogen creams. Is it pills? Is it injectables? Like how is it being prescribed? And then what is the safe and efficacy way of doing this with women where cancer is not a concern? Because we know that's been always a hot topic for too much hormone cancer. There's a balancing act here. So how do you manage that component of giving hormone replacement therapy and managing the patient in a healthy, balanced, way?
Absolutely. So we know that, estrogen is definitely beneficial to women. And now you talk about the breast cancer risk. So, what we have to understand that giving hormones, menopausal hormonal therapy, we don't call it hormone replacement anymore because we're not really replacing the exact amount of hormones that we were getting pre-menopause, right? So we're giving a lower dose.
A supplemental dose.
Absolutely.
Like,
So it's a lower
maintenance dose of sorts, right?
Yeah, it's a lower dose. And so definitely what you do is you have to do what we call precision therapy. Basically, we take a look at the individual in front of us, right? So women are not a monolith. We can't say that all women should have estrogen or all women should not have estrogen, right? We have to do a personalized approach. So we look at the patient in front of us, we see what her risk factors are and whether or not hormones are going to be helpful to women, right? So currently what the North American Menopause Society, the guidelines that are out there, what they state is that women, based on getting what their history is, getting their medical history and things like that, women are eligible for hormone replacement within 10 years of menopause, within 10 years of when they go into menopause or less than the age of 60, right? So it's it's either or. Say if a patient is they end up in menopause, they go through menopause at 54, right? They still have that 10-year window.
Right.
And the reason why they say 10 years is that they don't know how efficacious estrogen will be after those 10 years, because a lot of times those chronic conditions that we have already established. So we don't know if estrogen is now going to be helpful once those conditions have already set in, right? So mainly we're talking about like buildup of plaque.
Right. And you did mention risk factors. Are there certain populations or certain percentage of people that where estrogen just won't be applicable based on if they're a high risk breast cancer, potential, or is there still a way to do this with patients that have maybe like a BRCA gene or some other high risk, family history of breast cancer?
Yeah.
And we're only talking about breast cancer. We're talking about also like ovarian or other types of cancers.
Right. So again, I think those are fantastic questions. And I think that, again, you have to take a nuanced approach. You have to go and take a look at that history. I think that, people that are, say, contraindicated for having a hormone replacement are those that have active liver disease. Perhaps they have a hormone-sensitive cancer, right, that they're actively kind of being treated. So we wouldn't be treating those patients, right? Patients with, the thing that comes up is, what if a patient has a history of blood clotting disorders, right? Do we give them estrogen? Somebody with factor V Leiden, can they get, which is a blood clotting disorder, would they be able to get estrogen? So what we know is that there are certain formulations of estrogen that are actually safe, and research has been done on them, that they can actually get estrogen. Right? And whereas so we know that the oral estrogen pill, has a slightly higher increased risk of causing blood clots and stroke. So we have to kind of watch that. But if you take transdermal, meaning like the patch, the estrogen patch, there's definitely lots of research done on that. And you have a lower risk with being on the estrogen patch. And also there are gels, like you were talking about. There's the estrogen spray. And again, that goes through the skin. So there's a less risk of a blood clot with, say, the patch or the gel, as opposed to if you take an oral estrogen. So definitely, you know, there are different ways to take estrogen. There's also estrogen ring as well, which is systemic, and you can get, you can take that as well, and that would be placed in vaginally. So different formulations, you know,
yeah,
you
based
have to
on
tailor
the patient's needs and what's maybe, you know, best for them at the moment, you know, determined by, you know, a professional like yourself. So estrogen therapy. So what are the positive effects? Like, you start talking about all the things that can go wrong during perimenopause. What can a woman expect to, you know, experience being on estrogen? What's the upside?
Right,
you know,
absolutely. So there's tons of upsides to estrogen, and I think so. What I think people have to understand that they don't have to take pellets. You know, I think that there are some women that think that, oh, you know, pellets are safe. Pellets actually, you know, the American College of OBGYNs does not recommend pellets, anything that's compounded, because we have FDA-approved medication. We have, you know, they want something that is quote unquote bioidentical. So we have estradiol. We have estradiol that comes in a patch that is bioidentical. So we have FDA-approved medication. You don't have to go the pellet route. You don't have to go that compounded route. For any woman that goes on estrogen, if she still has a uterus, she has to take progesterone. So you mentioned progesterone. Progesterone can also help with sleep. So the reason why you do that is because
what is the reason for that? What's the balancing of that?
Absolutely, absolutely. So the reason why is because estrogen by itself can cause an increase in the lining of the uterus. So to prevent that, we have a woman also take progesterone. So that's why for a woman that has a uterus, also they need to take estrogen along with a progesterone to balance that out. And progesterone, we know, also helps with sleep in some women, with a lot of women that have, because we know that you can have the hot flashes, the night sweats, and then when you have those night sweats, women are not sleeping well, right? And so they're exhausted, they're tired in the morning, and so it's really important.
Is that also a pill, or is that also could be a cream?
So yes, so cream. Estrogen is it's a pill.
Yeah, okay.
It's a pill. Right. So sorry, we're talking about progesterone.
Progesterone,
I'm thinking of estrogen. So progesterone, yes, it's a pill. So it's micronized progesterone, and it's a pill that you take at night. And the reason why is because sometimes it can make you a little bit tired and sleepy. So you take that progesterone along with the estrogen. You can also do the IUD, Mirena IUD, because that has progesterone in it. And so if you already are on the progesterone IUD, then we just give you the estrogen patch to go along with it, and that'll give you the benefits of the estrogen. So what are the benefits of the estrogen? Well, of course, it prevents osteoporosis, which we know is a huge problem for women as we get older. We are, you know, 1 in 2 women will have an osteoporotic fracture as we get older into our mid-50s. So that's really important. So it prevents osteoporosis, prevents vasomotor symptoms, prevents night sweats.
Now, prevents osteoporosis, but may not treat it if it's already started.
Right. So
if you already have a certain amount of bone loss, then you may need other supplement like a Fosamax, or there's new medications with the shot and
the Forteo, which is the shot, right? The bisphosphonates. So, but estrogen, you can actually take estrogen if you have.
You can still take it. It may prevent it from getting worse.
Right. So estrogen, you know, other things that help with osteoporosis we know is exercise, increasing your weight-bearing exercise. That's really important to increase your bone density, right? We know that. We know also to keep our skeleton strong, we need strong muscles. And so that's why we really encourage that weight-bearing exercises, which are going to build that muscle, which are going to increase metabolism, which is going to prevent that weight gain that a lot of women have in menopause, that is really upsetting for women, because all of a sudden, you know, they're eating the same, they're doing the same things, but all of a sudden now they're getting, you know, they're noticing that they're getting a lot of weight in their mid-region, and that's because of the redistribution of fat due to the decline in the estrogen. So it's really important. So you were saying, what benefit does estrogen have? Well, it helps with muscles, it helps with bones, it helps with, you know, we do not give estrogen for a cognitive decline, but it does help. It helps with our brain. We have estrogen receptors throughout our whole body, especially in the brain as well. And so we know that giving estrogen does help. We know it prevents reduces your likelihood of colon cancer. It decreases that genitourinary syndrome of menopause. So it'll decrease your overactive bladder, that vaginal estrogen. It's going to decrease recurrent UTIs, which we know that women, as they get older, have an increased risk of urinary tract infections. And so, and a lot of times women in nursing homes get urinary tract infections that can lead to sepsis, that can lead to death. So it's really important that even if you decide you never want to go on estrogen, it's not something that you want to do, whatever, then I really, think that it's super important that you at least go on vaginal estrogen, because it's going to prevent this painful intercourse. It's going to keep the vulva healthy. It's going to prevent recurrent UTIs, prevent overactive bladder, increase lubrication, all of that stuff that's so important.
Yeah. Well, it sounds like the upside is definitely, outweighs the potential risk, especially when working with someone like yourself, where you're monitoring your patients, you're working with your patients over a period of time, and maybe things aren't going unchecked, right? For periods of time. I think that's some of the concerns in like the mass market of like healthcare these days, that things go unchecked and things aren't balanced. And so you're working with your clients on a one-on-one basis. You know what they're taking. You're following their chart. You're following them from, maybe like you said, puberty through menopause. If you're fortunate to build up that clientele, which would be wonderful for your patient to have that long-term history. And I think that's really the key, is explaining to the patients, hey, do this, we'll monitor everything, the risk is small, but the upside is tremendous. So I think this is what the viewers need to understand, is that it's not just, you read one thing and say, oh, I can't do that because it causes this, or I did that, because it's not always correlated unless it's, obviously, some kind of like long-term study or whatever, but it seems like the studies are there, the efficacy is there, the safety is there.
100%.
And then of course, the one thing you didn't really mention, or maybe we didn't stress out, is like libido. How does it affect the libido? Does it help? Does it help with all of the negative sides that people go through?
Absolutely. So I'm so glad you bring it up, because there's so many things that go with libido. When we think about libido, it's really important to go to a doctor that understands libido and how to, help women out. So, one of the things that we do as sexual medicine doctors is we use the biopsychosocial model. And what that is that you look at a woman, and assess her biologically. So as a gynecologist, I would take a look at, her vulvar health. And, as we talk about it, perimenopause, menopause, right? So she's all of a sudden, she's starting to experience, because of the decreased estrogen, she's experiencing pain with intercourse, right? Anything that causes pain, you're not going to want, right? You're not going to find pleasurable. So of course, that's going to cause decreased libido. You're going to think there's something wrong with you, and perhaps because there's such a stigma and you're not talking to your doctor about it, you may not be getting the help that you need. That's the first thing, right? The other thing is that we know that estrogen, along with testosterone, also starts to decline a little bit. There's something called hypoactive sexual desire disorder, which is another way to say decreased libido, and it's not a problem unless it bothers the woman. If it's bothering the woman, then it is a problem. And we have 2 FDA-approved medications for that. And 1 non-FDA approved medication. So I'll tell you what those are. So one is, there's something called Addy. Okay, both are the medications that are approved for libido in women. One of them was approved in 2015, and I'll tell you, a lot of gynecologists don't even know about it. And it's called Addy, flibanserin, and it acts at the level of the brain. Okay, and that's how it increases libido. It's a medication that you would take every single night. And you take it, you can see for the first 4 to 6 weeks, if it's working, fantastic. If it's not, then you may want to switch to something else. There's another medication called Vyleesi, which is an auto-injector, which is basically you take it about 45 minutes before you're about to have sex. And again, it works at the level of the brain to increase libido, increase desire. And then the third thing that we use is testosterone. We use testosterone.
I was going to ask about testosterone.
Yes,
because you kept saying it goes down. Okay, so is there a need to bring it up in females? Everyone hears about it for the men's health. There's a lot more focus on men's health and men's performance and men's this,
that. Because all the research has been done on men. That's why. So we always hear about men's health.
So it's interesting, because women may not even know that there is actually medication for these things.
Exactly. I agree with you 100%. So, testosterone we can give to women. So in 2019, there was a consensus statement by the International Society for the Study of Women's Sexual Health, the Endocrine Society, the American College of OBGYNs, and they formed a consensus statement that said that women can actually have testosterone to help with this hypoactive sexual desire disorder, this decreased libido. And the way that we give it to women is 1/10 of the dose that we give to men. And it's given as a cream. And you can apply it to the back of a calf. You wait for it to dry. But basically, it's to help increase the testosterone level in your body, because we know testosterone helps with libido. And so we can give testosterone to women. Obviously, you would have to go to a practitioner that is checking levels. We want to put that testosterone into the normal reproductive aged woman's testosterone level. We don't want to have it become super physiologic, right?
Yes.
In higher doses, because you can have some side effects that don't go back. So even if you discontinue that testosterone, it won't go back. For example, deepening of the voice.
Yes.
That can happen in women that have super high doses of testosterone.
Right.
That's why you always want to make sure you go to a practitioner that's checking those levels and seeing whether or not you actually need testosterone. Right. And to make sure there's not something else going on, right? So we talked about the biological component, right, of painful sex, but let's talk about the psychosocial aspect of decreased libido. If you have new onset anxiety and depression that can develop in women in perimenopause, menopause, even those women that have never had anxiety or depression, they can develop anxiety and depression. That's important to understand, because again, it's because that estrogen goes down, and we have all these estrogen receptors in our brain, and they're not getting the estrogen that they need. And so women can develop new onset anxiety and depression. So if you were talking about libido, these women can be suffering from anxiety and depression, which we know can definitely affect libido. Medications that we give for depression, SSRIs, also affect libido, and that's important to understand, right?
Right.
So the decrease in serotonin is going to cause a decrease in libido. Actually,
so there's a lot of biochemical, a lot of things going on that have to be addressed to see like what is causing and what can potentially help the patient.
Right.
And again, I think having that, use the word concierge again, having that focus on the patient is important, because again, you could take the time to go through the proper testing, review the test, review the levels, try a few things, have a proper follow-up, see what's working, see what's not working. Like,
Right.
in our world too,
Right.
like, being in the chiropractic, physical therapy world, like not everything we do works at the beginning. It takes time for patients to start to recover based on injury, whatever, but sometimes you got to tweak your approach, tweak your, your techniques. And the same thing with when you're dealing with blood analysis, lab analysis, pharmacology, you sometimes have to kind of, it's a balancing act, right?
Right, yeah, absolutely, 100%. And that's why, this is where concierge medicine works.
Yeah.
Because, you are paying for that doctor's time. Typically, my first appointment is between 60 to 90 minutes. When was the last time you had an appointment with a doctor that spent 60 minutes with you, right?
I don't think.
Like
total of my lifetime.
Right, exactly, right? Like never.
Yeah.
So that's why concierge medicine is so good, because you actually have that time to spend with that patient. You can actually figure out what it is that's bothering them. Where is it stemming from? Is it, one thing we didn't talk about is that I also offer sex coaching, and that's because there's so many aspects of intimacy that is, involved with kind of the emotional aspect of it, right? And coaching is all about helping the patient move forward in their relationship. So where is it that patient is stuck in their relationship in terms of intimacy, and how can they move past that? I had a patient actually just come to me most recently where she has a really bad relationship with her own body, right? So how does she improve that? How does she get into a space where she loves herself, loves her body, so that then she can share that relationship with her partner, right? So there's so much that we don't talk about.
Do you ever do couples therapy?
Yeah, absolutely.
It takes two to tango sometimes, right? So
100%.
Whatever that couple may present as,
Exactly.
that's fine, but
Exactly.
it may not always be that you're patient. It could be the other side, right?
Right.
So,
Exactly.
yeah.
So that's why it's so important to have those long, in-depth conversations with patients, because if they're seeking a solution to a problem that has multiple answers, you're going to have to figure out what it is that they really need, right? And when we talk about the social aspect of the biopsychosocial model for decreased libido, is it a single woman that's working multiple jobs that now intimacy is just another thing on her list of things to do?
Right.
So she's not really going to enjoy it, and so that's going to cause decreased libido.
Especially in today's day and age, high pressure jobs, stress for, men and women, just in general life, all of these things can have an effect on our personal lives, our social lives, our sexual lives. And as we, age in the process of, development, these things with the hormones get out of whack, and they probably need to be addressed. So I think it's great, doing what you're doing. And like you said, you mentioned pain. We didn't really get a chance to talk too much about pelvic floor dysfunction and pelvic health, but there's so many aspects where women are experiencing pain for maybe other issues that are going on, and you could address those issues, recommend other types of therapies to help out. I know pelvic floor therapy has become a big thing.
Huge.
Yeah, so and having the appropriate professionals to work with. So I think that's important.
To your point, for sexual medicine, the ideal triad is really having a pelvic floor therapist, a sex med doc, and having a sex therapist or a sex coach to help the patient in all three aspects of their life, specifically for women, right? Like you mentioned, pelvic floor dysfunction can wreak havoc in a patient's life, especially if they're experiencing something like vaginismus, where those muscles around, the vagina tighten up in anticipation of any type of penetration, whether it's a pelvic exam, whether it's tampon insertion, whether it's penile-vaginal intercourse, any one of those things, right, can cause pain. So really important for you to go to a doctor that can assess that and then refer you to a pelvic floor therapist that can help you with those muscles, help to relax those muscles, give you exercises for those muscles. I mean, pelvic floor therapists are really key in any type of sexual dysfunction.
And having, like you said, having a whole team of professionals, so unfortunately a 30-minute show is not nearly enough to discuss, your specialty and what you can do to help, women's health. And, really you're not helping just the women, you're really helping potentially an entire, couple, together to help solve some of the problems. But being a concierge medicine, being an OBGYN, dedicating yourself to women's health is very admirable, and I appreciate you coming on the show. So thank you very much.
Thank you. Thank you so much for having me. I really appreciate it.
So I just want to say thank you for watching Health IQ. We'll see you next time, and check out Dr. Lodhi's practice in Chappaqua, New York. Thank you very much. Bye-bye.